Today we're here for the 5th episode of our Every Mind Matters Roundtable series. This one we're calling Inspiring Empathy, Learning Through the Therapeutic Relationship. Today we have a group of mental health providers with us who are going to help us understand psychosis better through their experience of treating young people through their first episode of psychosis and their journey through recovery. So in all of our episodes, what we're doing is bringing people together to talk about psychosis in an attempt to help destigmatize it. So we're going to start today by meeting our panelists.
Okay, I will be first. My name's Gwen Smith, and I'm a licensed clinical social worker. I'm licensed in Louisiana and the state of Florida, and I've worked in Louisiana, Oceans Behavioral, I guess can we say, and I've worked residential substance abuse treatment for a few years, and now I am doing private practice. And so that's what I'm doing.
My name is Kangxi Thakur, and I'm a child, adolescent, and adult psychiatrist at Tulane, and I work at Epic NOLA, and I also work in Jefferson Parish Schools, and I also work in another kind of smaller Tulane clinic.
I'm Claude Giat. I am an LPC and an LMFT with a focus on families and often couples. Began in private psychiatric hospital and worked there for several years, and then branched out into private practice. More recently, worked at the public mental health clinic in Mandeville, Louisiana. And I practiced on the North Shore and Metairie and New Orleans throughout my career. So love the area and know it well.
And so both of us are sort of serving on the panel as well as clinicians, also seeing patients on a everyday basis at Epic NOLA and providing care. So first point of discussion is that I'd love to hear from everyone about their experience being in a therapeutic relationship and providing treatment for individuals, and like kind of how it's impacted how you understand their recovery journey better and kind of what they're going through. I think it's really powerful to be with people in those moments, and providing treatment it's kind of a gift that we all get to have and have these experiences. So I would love to hear yours.
Who would like to go first? I'll take I count it all joy to get to work with young people who are trying to understand what in the world has happened to them oftentimes. And no two people are alike. And there, I think for the public is often this sort of misunderstanding that all mental patients are this or that. And they're as unique an individual as all of us are, and because they're just like the rest of us. And struggling to understand what is happening and how do I get my old self back sometimes. We don't go backwards, we always go forward. I try to explain. And so how do I learn to live then with what has happened and effectively cope with this illness that I've been diagnosed with? A lot of resistance oftentimes to the diagnosis, so we don't try to bring that up and make that a big issue as much as how we deal with the struggles that you find yourself dealing with in relationships and in work life and trying to live just a regular life. And so for me as a clinician, I must tell you that I often feel quite helpless. I learn from everyone I work with because I don't have the answers for my folks. I'm working to help them find theirs. And what a joy that is for me is the short version, really.
Yeah, some of what you said definitely resonated with me about not having the answers to why someone is experiencing what they are or what it means or why their experience feels so different from so many around them. And I think that what helps me is to recognize that my primary role is to be there and care about what their experience is and try to understand what it means to them. And that's been, I think it's just a grounding part of doing psychotherapy and other types of treatment with folks. And I've had a lot of different kinds of experiences with people with psychosis. Some kind of my first experiences were when I was a psychiatry resident, and people were usually in a very acute or difficult state in a hospital setting, and families were really desperate in those moments for support and help. And that it felt like with how much was going on in the hospital setting, often they were really craving some sort of support and nurturance. So just even being there to provide a caring sort of space and support for people is so impactful. And I realized that early on. And I think that I also had experiences early on where I really wanted to understand what people were going through. And I would hear that it wasn't really something that could be understood, that it was nonsensical, or that they weren't in a place to be understood. And that never really made complete sense to me. And I'm glad to now be working in a place with people that don't really have that experience and are really trying to understand what people are going through.
Well, I was thinking about listening to both of these guys and then thinking about different experiences. And one of the things that I think about is when you said, we don't go backwards, we go forward, is to get those families to understand that, sometimes the person that they know is really different now, and to accept this person for where they are today, but it's still going to be okay, if that makes sense, And then thinking about how sometimes we don't necessarily understand the experience that they're having, but sometimes we can understand the feeling of not being understood, and then we could kind of empathize with the fact of not being understood, not so much that I can see what they see or hear what they hear.
Yeah, I often equate it, or will talk about that we disagree on a lot of different things. I have got a different opinion of, what's the best way to eat ice cream, and someone else might have a strongly held belief about it being another way. And so it's not like an uncommon thing to have different types of experiences, and we can agree to disagree. We have to do that all of the time. And I think sometimes in treatment with people having, because it's so sudden and it's such a new and intense new experience that it seems unexplainable, and it might be difficult to explain, but it's sort of it's very similar to how we live our life every day. Like tomorrow is going to be different, and we kind of figure out how to come to terms with that. It doesn't mean something about you that's wrong. It's just kind of part of life. Not to marginalize the intensity, but because they already have skills, right, in navigating change. So it's like, okay, we just got this one might sound a little bit more unusual. This one might feel different, but you can use what you've learned and apply it to this situation.
Yeah, I think a couple of you have touched on this, but one of the things that's really enhanced my understanding of psychosis through working with patients and families is being witness to the vulnerability that people are willing to sit with when they walk into our clinic, when they walk into a session with a therapist or a psychiatrist. This confusion, lack of understanding, feeling that their world has been turned upside down, and then being willing to just sit with that, share the nuances of that, the details of that, I found to be really inspiring. And learning from our patients that their ability to sit with vulnerability helps me to sit with my own vulnerability in these sessions.
And wanting to not feeling like we're all just trying to fix something or just trying to mutually understand something.
Yeah. And I think what you said was you were talking about caring for people, and that is just a huge part of this. And we're on a journey with these individuals and with their families, and we don't necessarily have all the answers, and we can't necessarily fix things immediately in the long term. But if we can build that rapport and be with people, help them to feel safe and understood, then that goes a long way.
I think of some amazing moments with like teenagers or young adults that are still engaged with their family or still supportive of family. And it's like you are working with them and you get to this point where you see their like independence and knowledge of self get, growing. And then they would come in and be like, well, Dr. Weiss, you need to call my mom and tell them blah, blah, blah. Because they're like, no, I understand myself. You're not understanding me. And Dr. Weiss, you need to go talk to her. And I'm like, oh, that's great. I mean, I don't, not wanting conflict, but you could tell that they're like taking, that
They're becoming okay with.
Yeah. Yeah.
Well, if I can share from my own journey growing up in a family where mental illness was present, and I remember as a young child seeing my mother psychotic and going through an episode, and just that feeling, trying to protect my sister and being scared and crying, and how do I deal, and what do I do? Dad wasn't home, and just implanted in me this concern for people and care that when I got older and went to school and studied. And that was all fun and everything, but that's school and it's not the real world, and you get out and you deal with people and you have to learn how to actually connect. And I think because of my own experience gave me a little bit of that I could hear in a way that reassured and brought some comfort to folks and helped them. And that's what I enjoy. You were talking about that. We've all talked about that helpless kind of, how am I going to help this person? And we don't have all the answers, and yet they're often looking to us like, can you talk to my mom? They want us to provide some hope, some help, and we do that. Mm-hmm. We do that. We instill hope and a belief that things can improve and their lives can get back to a functional status where they can be successful. And we're, again, coming from a family standpoint, being supportive of that person who's suffering with this illness that they did not choose. And they didn't cause or create oftentimes. It's just thrust upon them. And they're feeling lost, and then the family is trying to understand what's happening. And we've talked about stigma and how families will stick their own family member oftentimes. Where I live particularly, we can't have a family member who has an illness. Well, we all have stuff. Mm-hmm. And this is another one. We'll deal with it. And so helping families understand how to love, connect with, and work with their loved one is an important part of the journey for me.
Yeah, we're like looking to overcome stigma within our communities around psychosis, but there's stigma within families, right? And then individual stigma, right? Individuals not wanting to, not understanding perhaps, but also not wanting to admit that psychosis is what they've experienced.
That brings us to kind of the second, I think, good discussion point of even within the mental health community, there's a bit of a misconception that people with psychosis are successful in psychotherapy, or like that you can do psychotherapy with someone with schizophrenia or schizoaffective disorder. And there's this almost like stay away from that notion, which is very, very, very different from our experience. And yeah, I would love to hear your thoughts on that. And how do we encourage that to change?
Well, my experience has been many of the folks I work with are very bright and capable people. And they're suffering from a very unfortunate illness, but they're very bright and capable, and they want to understand, and they want their families to understand, and they're trying to make their way. And it's baffling for us as clinicians oftentimes, because like I said, no two folks are exactly alike in terms of how they're experiencing that. So helping normalize their experience as much as is possible, that this will be a part of your life and you will learn some coping skills, and we'll work together and help you through this. And And folks do. We see success stories, and my goodness, that's what keeps me going, right? Seeing people recover and get into an active phase of being able to do psychotherapy. And I'm just going to throw this out here, but I get very frustrated oft times with clinicians who don't understand the illness and working with folks with severe disorders. And they have their misconceptions, their own beliefs about what it means to work with folks who are ill, very ill. And again, because I'm thinking, like you were talking about, when you first work with folks who are in that first phase of thought disordered, mood disordered, everything's just out of whack. And thank goodness for our medical providers who get them on the right medicines and get them stabilized, and then we can begin to engage further in how to understand and battle against their illness and work for success. That's the most exciting part of what I do. It's just fun to watch people take control of their lives again and see that they can do that.
I think we really have to change the way that we train and educate people in psychiatry and psychology, social work, counseling, all of these fields, and get rid of this dominant narrative that psychotherapy does not work. Meaningful psychotherapy, only supportive psychotherapy. I think, as you mentioned, ambitious psychotherapy doesn't work. That's something that I think, unfortunately, many of us learn when we're young, and it might not when we're training, and it might not completely make sense to us, but it gets reinforced at various stages, because then you're more hesitant to take on patients that have psychosis. And then, your mentors don't have that kind of experience. It sort of perpetuates it. So I think we really have to change that narrative and help people understand that we all know that the most important part of psychotherapy is the relationship. And there's no reason why building a relationship with someone with psychosis would not help them, number one. And then also understanding that there is meaning within what they're experiencing, and not sort of thinking of it as some sort of noise, that there's nothing there to really understand. I think if those two basic things were communicated to young trainees, it would make a huge difference.
And I think that, sometimes when you talk about the training, just start with, I care about you, and then just like, because if a person knows or feels that I care about them, then it's like, okay, they're willing to work with me and not treat me the way most other people probably around them have treated them, because they just didn't understand. But if we just start simply with, I care.
Yeah. And I think that's very, very, very true. And I also think, going back to the training part, having to revamp our systems of training, incorporate ambitious psychotherapy into that training, but also for those of us who have been trained, right? We've been fortunate enough to find people who are ambitious about teaching others. And our mentor, Dr. Michael Garrett, I think has really helped affirm what we've known to be true, that this psychotherapy, psychodynamic psychotherapy within this patient population is 100% possible and wholly helpful for young people.
Yeah, and the value, be it any type of mental health profession, that you're engaging individually with someone on a weekly basis, that, it doesn't just happen in 4 weeks. It doesn't just happen in 8 sessions. And we have this idea that we can give someone a 12-week course and things be better. And maybe we train sometimes people going into these fields that this is a way to give a short course of intervention that's helpful. But 12 weeks in the life of my young person when their first psychotic episode, that is nothing. In the United States, people are usually having psychosis for more than a year before they ever even get to you. So the idea that is what it that's all that it takes, it just doesn't even correlate even with what the science that we do have. And I mean, gosh, I feel like we just get started with people after a year. they're and then feeling comfortable and being willing to being willing to share. And, I think at Epic, there's a very collaborative relationship between the psychiatrist and the psychotherapist, which is great. And then sometimes it happens that, individuals might be a little uncomfortable meeting with two different people. I remember when we first started, I had one young guy that I getting to see me, he's like, yeah, I'm done. Like, that's it. I'm only coming to you. You got all these people you want to introduce me to? No, thank you. Like, but I'll come see you. So I was like, okay, so I'm going to see him weekly for a while. Like, this is what, we've got to start. Meds are good now. We've got to start working through the therapeutic piece, psychological piece. But being ready as a psychiatrist or being ready as a therapist to provide longer-term longitudinal care while someone is going through this long recovery process, and then their own individuality that they might want to work on outside of psychosis. Because that's often what it turns into. Is like, okay, we're done with that, but I'm 23 and I'm struggling with my work and I'm struggling with relationships and every other reason that people go out to seek therapy.
Right.
And so many times it's like entities outside of us that hold us to these 12 weeks, and what we have to do in 2 minutes. It's just like, really? So it's just, and so many times we run into that. So I think it was I know I had heard that this doesn't have to happen, I think, with Epic. That, it's like, because like you said, once this is done, then because I didn't get the skills because of my mental health to know how to be in a relationship or do other things, now we can continually help them with all those phases, and that's, but, again, entities outside of us has told us in the past, no, this is it. This is how much time you have.
And what rationale is that based on? I mean, it's really unfortunate, and I feel comfortable in this space of bringing that up. Is that, and I tell my trainees and the students and residents that train with us that, these sort of guides, you always need to think about why. And why did that come to be? That's sort of the approach to XYZ. And if you can't find a rationale based in evidence, then you should question why that decision was made. Mm-hmm. And ultimately, you have a role and you have an oath or whatever your mission, however you and your I want to be a good physician. And I know best that the therapeutic relationship is the main thing that counts. And if that prescriptive way of doing work with an individual is outside of what I believe based in evidence is the best for individuals, then I need to think about that and to...
I mean, I recognize, though, that that's really hard for people to do. And I think what helps is to connect with peers and work together and get support. If we weren't trained to understand or work with people with psychosis, then we need to reach out and sort of connect with peers and continue peer supervision. Because there's so much as providers that we're not experts in everything that we're gonna work with. We're constantly learning, and I think having community with our peers can really help us, face these kinds of issues too.
Inspired when it's really, it's hard.
Right. And I think, right, as therapists, we have our clinical instincts, right? And if one's clinical instinct that it is wrong for one to be discharged after, right, 12 weeks of care, listening to that, but also using that as an impetus to reach out and find a colleague who might have more experience in this, or reach out and find a training program. Like, midlife is not too late to find, training or a new mentor.
Become a psychotherapist.
Yes.
in whatever way that it leads you.
Yeah.
Okay, so moving into our next topic, because I could talk about that topic for the rest of the week. What are some common misconceptions that you guys come across in your work?
I don't know why y'all would miss that. That's just so. Wait, now that I'm saying this, it is funny. Remember it was on something that I saw called NOLA. This is what it didn't come from that, but it was that overactive imagination that society has a tendency to water it down to an imagination instead of something's actually going on in their brain, and they're experiencing something very, very different than you are. But the misconception, it appears to me, that there's just the imagination and they just want to leave it there. It's not their imagination. So.
Well, and I think that a lot of providers think that they just need medication. You can't do anything beyond that. And I know you mentioned that. We talked about that some. But there's so much more. And again, meeting Dr. Garrett and hearing the depth psychotherapy and working with people to help understand, might there be a root for the thoughts that I'm having that you're describing, the overactive imagination? Might there be something in my past that sort of stimulates that and gets me thinking that way? And how do I better understand that? I'm a systemic thinker, so I like to see the person as a part of their group and how they, and by the way, I love being with a group of like-minded folks. It's a thrill for me, and I feel honored to be here because of the work that you all are doing and we're doing. And but to get people bought into that these people are part of a system, and we have to understand that and how that impacts them. And they're often folks who suffer from mental illness are often seen as isolated and individual, and unfortunately that's a part of our culture at large. I think that we're all just independent, every man, woman, child for themselves, and we're not. We depend on one another, and it's important to see our folks that we're working with that way, that they're part of our system, and we're at large, and the world is impacted by what we do and who we work with and who we see and how they affect. And I'm glad to hear, I think I was mentioning this earlier, that there's this big emphasis now on mental health and the crisis that we're experiencing nationally, and it's not just nationally, it's worldwide. And so that there is more focus, we need now more funding, speaking of which, limiting the number of visits and things like that. We need more funding, we need more tools, and so much is being done. I think that a lot of folks believe that this is it, and we don't have to. We're still doing great research. The neuroscience is incredible, the stuff that's happening with understanding how brains sometimes are misfiring and they're needing some help, and then us being a part of that and helping folks understand and work with their treatment team and all. Again, I just think it's a systemic approach where we all come together, and I love hearing my medical friends and how we can be a team and help, and not just, let me refer you to somebody and shove you off. Although when they refer to you all, that's a good thing, because they're going to get the help they need here. So, and thank God for you all, and for organizations in communities that are seeking to help. Folks often don't feel there's any resources, and they're limited, I will say. But I do think we're moving forward, and research is helping. Hopefully we can get more funding, get more help, and help people find hope. My goodness. Instilling hope. I read years ago that the provider who, we're taught to be sort of aloof and and I don't do that, But I engage and join with folks, but not doing that can instill despair in people. And that for me was so impactful to understand that we need that connection with one another. And I think that's a myth that you can't connect with these folks. Of course you can. Of course you can.
I think like from being a psychiatrist, I think just in general in the medical field, the misconception that the schizophrenia spectrum disorders are somehow have 100% across the board a poor prognosis and there's nothing that we can do, which, fortunately in the last, number of years, we're learning that that's in fact not true if we provide them really good care from the beginning. But now we're, in these conversations about, okay, so we're providing really good care for a while, and when they leave really good care, things start going wrong, which is why we, provide longitudinal care. But, that we would never approach other chronic illnesses in the same way. We would never say, okay, a good couple years of treatment for type 1 diabetes, which starts usually in adolescence or young adulthood, and then be like, and now and no more. Like that's just, so that's, there's an equity issue of like what, and it's not me medicalizing schizophrenia, it's not that, it's just the reality that, this is an illness that affects someone's brain. And it deserves the same respect because it can be really, really detrimental. And we've seen that throughout history. So it deserves the respect and attention that any other illness that a young person would develop gets. And so like if our perception and our approach is to give it's give the individual the same type of approach that we would give anything else that, without treatment is not going to go well. If we gave it that same approach, then maybe people, maybe the trickle down would be a little bit different.
Well, and what we're doing with Calm NOLA, what you all are doing and working hard is the early intervention. Let's get involved early. And I think that's so crucial because we know that the illness over time can cause great damage to one's psyche and brain. And so we want to get involved early. And I hear the young folk that I work with, that I'm fortunate to work with, want to get better. And I think that's a mistruth or an untruth that people have, that they don't want to get better. And it's just not so. They're desperately wanting to get back on track.
Right. That they don't want to get better, they can't get better, and they can, and they do. And that's why, right, this early intervention is essential. And I think, there's, we hold hope for all these people that we treat, and people meet that hope, they join with that hope. And, we've been so lucky to see young people graduate from high school, graduate from college, apply to graduate school, go off, get married, have babies, like do these things that others are doing in their lives without a chronic and severe mental illness. And I think a misconception, right, just playing into these misconceptions, is that people can't and don't, but they do, and they will continue to with early intervention.
I think another misconception that keeps people from seeking treatment is that psychiatrists and providers are going to label them and prescribe to them exactly what it is that they need, and not be open to their experience of it, and not be open to different ways of thinking about it. And some of that may not be fully a misconception. Some of that is grounded in history and reality, but that doesn't mean that all providers are like that. There are many providers that are very open to a person's perspective, and more we're becoming person-centered as a field also, and I think that I hope that people will recognize that there are people that are going to listen to them with an open mind. And yes, that they have certain, expertise or training that could be really helpful for them, but that doesn't take away that they're really trying to understand their perspective, their cultural perspective, their family's perspective. We aren't experts on all of that, and we don't think we are. Many of us don't think we are, and I think that I hope that people can feel that or take a risk on seeking treatment.
Kind of brings us to society and the community at large, misconceptions, and kind of how we all feel, or what we would do to educate. What are the messages that our community needs to hear to change these misconceptions and to address stigma? How you would use your experience to sort of guide that mission, because at Calm we do have that mission of changing perception. I mean, you mentioned the individuals, maybe being reluctant to seek care because of the maybe misconception of all providers being this some kind of way, and then when that's layered with every system that you touch having the same negative opinion of you, like it stacks against you. It's like, okay, well, my friends think I'm bizarre, and my family is being judgmental, and then at school they're telling me I can't come back, and then I, can't get a job. Doctors were going to treat me bad, and then I see on media and TV displays of people with psychosis being mass murderers, and I hear it on the news. It's just layers and layers and layers stacked against, in our case, mostly teenagers and young adults coming and taking this risk of coming into our clinic, and yes, there's everything that everyone's doing here, and y'all are all wonderful, obviously, but then there's just, you think about the battles that they have to face outside. So, which brings us to our final conversation point of like, how do we fight that battle for them, with them, but we want to get ahead of it to where they don't have to deal with that. So let's brainstorm good ideas.
Well, normalizing the illness as opposed to just crossing the street and staying away from someone, because a lot of and again, the media unfortunately shapes a lot of our opinions about stuff, right? So folks think that someone with a mental disorder, someone who stands on a street corner and yells at the bus going by, and or is acting just so. That's not how the majority of our folks are experiencing their illness. They're living private lives and trying to understand why they have these recurrent thoughts that they just can't deal with and understand. And so again, helping families, helping the public at large be able to connect with someone who is sounding different from what they're used to, and that's okay. Mental health patients are not violent by and large. There are those examples, sure, but that's not the common experience for me. And so helping them understand that you can talk to someone, you can meet with them and talk to them, and try to help them find the resources they need to get the help that they need. But invest in them, invest in that person's life. Don't avoid them, don't withdraw, because of the misconceptions that folks have about violence, about them being unhelpable, all those sorts of things. And we know that that's just not the case.
Right. I also think it's investing in the people who care for young people, right? Like thinking about schools and coaches and people who are interacting with these 16 to 25-year-olds on a daily basis, helping them to understand what the signs and symptoms of psychosis are so that they can help people get into the care they need ASAP.
But as we were talking about earlier, the school systems and all of the places where young people are, it's like they have how they do what they do, and they are really resistant to change, and it's like they don't, maybe they don't want something else added to their plate, or whatever. So do we make room for professional clinicians to go in their way? I'm not adding anything to the teacher's plate, but I'm here for those intimate settings that you were talking about, so just to educate and give information on for people who would want to do it.
Yeah, when even I think a lot of people that do clinical work kind of feel isolated, because you are usually in an office doing work. But then when you are, being a liaison with the person's school or with work, I find myself, if I'll talk about what's specific to that individual. Then I'm like, so have you ever really been around someone first experiencing psychosis? What's that like for you? What do you know about it? Do you want to know any more about it? And like, we're happy to come and tell you a little bit more about it, and try to like find those educational moments. Even like not taking advantage, but yes, taking advantage of moments that you have with people to like drop some information.
Yeah, it's interesting because a lot of times when you drop information, the universe kind of comes in and waters that information for you.
And we just need to keep sprinkling it every chance we get. And that's what we're trying to do with Calm, and seizing about these moments or creating moments, putting billboards up, putting signs on buses, putting signs on bus shelters, talking to people, and putting these conversations on social media so that others can learn in the way, in atypical ways, so to speak.
And so many of them show up saying, I just want to know I'm not crazy. I just want to know that I'm not crazy, so that you could, take that time to normalize their experience and allow them to be different. Different does not mean crazy. It means different.
Yeah, I think the peer support movement has been, and I think expanding on that could only help too. It can also help, I think, having more providers interface with the peer support movement would help their understanding and the way that they talk about patients to become more person-centered.
Yeah, absolutely. I'm glad you brought up the peers. I think they're an essential part of the work we do, and really giving them a pathway forward and allowing them to rise up into leadership positions, to really lean into their expertise of lived experience, sort of on a more sort of meso and macro level.
Yeah, and that I think our as we're kind of closing up, our young people, I think it's been incredibly inspiring to sort of see them go through their recovery journey, but then become advocates, and then feel empowered, and then when they're telling their story to other people around them, and that is so powerful. And we could give talks. I don't know how many hours of training Serena and I have done. Like, we could talk for days and days and days, and nothing is as meaningful and for like captivating as. And I think what moves change is like hearing from people who have lived it, and that is what I think is going to ultimately change like misconceptions that society has, because it's going to be people that are living life, practicing medicine, practicing law, in leadership positions, doing work, and being like, yeah, I've got schizophrenia. Yeah, like, so what? Like, but that's that's where change happened.
Sure. And I think it was one of my own myths that folks could have climbed to such heights that you see that person who's being successful, who has earned a PhD or an MD or whatever, and they overcame or are living with their illness in a very effective way. And those are outliers. Those are and that's what I thought. And then, you get involved and you find out, love that sound, and that it's not, that it's possible. And we've got to keep believing that for everyone we work with, that it is possible. And I think getting the public in on that as well, believing that it is possible. And other providers, too, who are not in our circle, they're not dealing with folks. A lot of providers are like, I don't want to. They don't know what they're missing. because it's exciting and it's fun and it is filled with hope. And I want to stay positive about what we do. You know?
Yeah, and thank you guys so much for being here. I think kind of in closing, I think the early intervention is a kind of a newer concept, and so over time, as people do go through early treatment, and we have more and more people growing older and getting into their lives, managing an illness with psychosis, that the future is really going to change. It's probably not in my lifetime because my patients are so young, but when they're older, hopefully they'll be the movers and shakers of this, and society will be inclusive, and there will be no more marginalization. So thank you guys. It seems like we're about to have a big change in the weather out there. But yeah, do you want to take us out?
Yeah. Yes. Thank you. Thank you for believing change is possible. Thank you for caring and for holding hope. And we encourage everyone who's watched this, who has found it inspiring, to share this with another clinician, another therapist, another mental health provider that you know, and follow us on calmnola.org and on our social media feeds. Thank you for joining us today.